To begin, let us acknowledge that Queen's University is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. We thank the Indigenous peoples of this area for their care of their land for thousands of years, and we hope to honor and respect them as we hold our virtual event today. I'd also like to take a moment to personally thank everyone for joining our discussion today. Our speaker this afternoon is Dr. Amir Khadir, who will be presenting on long-term antibiotics for Lyme disease with persistent symptoms, a pilot project with 468 patients. Dr. Khadir is a specialist in infection diseases and medical microbiology, practicing in Hôpital Pierre-Lagardeux, a community hospital in the Montreal metropolitan area, where he has been practicing since 1997. He has also served as a parliamentarian in the Quebec National Assembly between 2008 and 2018. Dr. Khadir has implemented in 2019 the first clinic dedicated to the treatment of vector-borne diseases operating within the public sector facilities of the Quebec health system. More than 500 patients have been evaluated at the Centre de Maladies à Transmission Vectorielle, which offers specialized care for patients with persistent symptoms attributed to Lyme disease, such as chronic Lyme, PTLDS, or otherwise defined chronic complications of Lyme disease. Dr. Khadir spearheaded a petition in 2017 that brought the Health Commission of the National Assembly to recommend the implementation of a Lyme disease action plan by the Quebec Health Ministry. The mandate was given to the INESSS to produce reports and recommendation on Lyme disease, where Dr. Khadir acted as an external reviewer. He's also took part in the advocacy work by patient groups that brought the Quebec government to follow up on the INESSS recommendations and announced in May 2022 the creation of a network of 5 referral centers and 10 satellite clinics called RQMCC to improve diagnostic and therapeutic management of patients with chronic multi-system syndromes such as persistent Lyme disease, whether the disease is serologically confirmed or diagnosed on clinically grounds only. Dr. Khadir is a member of the National Steering Committee of our RQMCC, which has a budget of near $21 million over 3 years. We will have Dr. Khadir present, and then we will open for questions from the audience. You can ask questions by entering your questions in the chat box, or you can raise your hand using the icon through Zoom. Please help us welcome Dr. Khadir to the podium.
Thank you, Veronica. Should I speak?
Yes, please go ahead and you can share your slides.
Okay, thank you very much. Hello, everybody. So thank you, Veronica, for your presentation. As it was mentioned in the introduction, I have been involved with Lyme disease patients since 2017, to be exact, when the Association of Lyme Disease of Quebec, a few patients came to see me at my office as a member of the National Assembly, and then from that time I got involved by the mere fact that I had to spearhead a petition from that association that went on to the National Assembly, then was instrumental in organizing some hearings at the National Assembly that I will explain, and that brings me today to talk to you about our project. So I will be speaking about the treatment of these persistent symptoms with long-term antibiotics. But before everything, and I know that it's not usual, but I want to, because I might forget at the end, I want to make a special thank to all those Lyme patients, especially the Association of Quebec, l'Association québécoise de la maladie de Lyme, the Lyme Disease Association of Quebec, and its equivalent, the CanLyme, to have contributed and accompanied me in this endeavor. I want to make a special mention of Carrie Beasley, who is a patient partner that many of people of Clyde Doren know well. Also, Professor Vet Lloyd of Mount Allison University, who has published extensively on the genetics of Lyme disease and its zoonotic expansion. I must also, of course, thank my hospital colleagues, the infectious disease service of my hospital, who have, with patience and with openness and with some, I would say, sense of curiosity, have accepted to allow me time to take care of these Lyme patients in this Lyme clinic. There is also Dr. John Alcott, who has given very precious advice in the beginning of this endeavor. The hospital administration, of course, was accepted in Hôpital Le Gardeur to provide sufficient funds to have these clinics opened up. And then, of course, a lot of patients who are today at this conference know well Sophie Finger and Karen Apréau. Sophie is the reception clerk, but much more than that, she's in somehow the backbone of this clinic, and Karen Apréau, who is the registered nurse, who was with us for the whole 2019 period. But of course, because of the pandemic situation, we lost her for much of the rest of the time until 2022. And then again, because of the shortage of manpower in Quebec hospitals, as is the case all over Canada, she is with us not more than 1 day in a week for the moment. I want to mention also one of my patients who is a health professional who got better, sufficiently better to return to work after the pandemic. But before returning to work, when Karine Apréau, our nurse, wasn't able, for a year, she twice a week, she was doing 4 hours of a ride to come and help me follow up with my patients. I want to thank her. And also Nima Mashouf, the epidemiologist in charge of the analysis of this clinic's database, who happens to be the companion of my life. Also, a lot of you know her. And Tanis Nelson, a graduate student who helped us set up the database. So what is all this about? When I began seeing and treating Lyme patients, I didn't realize that we will be in a long adventure, medical and personal adventure, because in that time it was out of the fact that some patients had heard about my implication in the parliament, that they began to register at my external clinic as an infectious disease specialist. But little by little, we realized that we have to set up a clinical register, because of the fact that the protocol and treatments that we were given were, of course, not validated, and it needed to be within a structured research project. So we have set up this patient registry to keep track of the evolution of these patients that I have seen through these 5 years, receiving long-term antibiotics, whether it's for a proven Lyme disease, which leads to persistent symptom situation, as it's for post-treatment Lyme disease syndrome, or a probable disease, or context in which the possibility of people having been exposed to ticks and their clinical symptom rendered it plausible, even in the absence of serological tests proving the infection. So the clinical question that we had to answer during all those years was two things. What's exactly the impact of these long-term treatments to the burden of the disease? in terms of the quality of life, in terms of functional impairment, were we able to improve patients and render better quality of life, and if possible, a return to normal work and life. And also see if in these impacts, the side effects and harms were in a dimension that was a problem with this type of protocol. But before going there, I want to very briefly talk about the situation of Lyme in Quebec, as it appears that it's possible that Quebec might be becoming little by little an epicenter of Lyme disease. You remember that yesterday in the presentation, there was questioning about low reporting and low level of diagnosis of Lyme disease in British Columbia. There are probably some very technical and epidemiological reasons. There was a question of also the role of the lizard's blood as an anti-Borrelia protein, which can cut the transmission process, but we have nothing of the sort in Eastern Canada. So let's see what's happening here. Since many years now, in Canada, we know through the investigations that were carried and published in 2005 by the team of Nicholas Ogden, that climate change has an impact on vector-borne zoonotic diseases. The key points of their research was that climate change, in fact, spreads the geographic presence of the ticks up toward the north, and also renders the habitat more prone to increase the possibility of transmission. So tick population is driven by temperature suitability towards the north, and the transport of infected ticks. One major finding is that the transport of infected ticks over large geographic distances throughout Canada by migratory birds, in fact, makes Lyme transmission possible almost anywhere in Canada, even if it's in low incidence, but it is possible almost everywhere in our territory. A lot of you have seen this video of that is on CDC's site, which shows the expansion over the time of the Lyme disease incidence from its first epicenter, which was Connecticut and neighboring states, to the north and to the west. But the actual picture that you see for 2019 is the absolute incidence of the infection, which doesn't give an idea about the incidence rate and which states are actually going upwards. But if we look into the details and dig into CDC sites, as you see for 2019, Maine, New Hampshire, and Vermont are leading the incidence rate all over the United States. So by absolute terms, of course, Connecticut remains, because it's much more densely populated, the highest ranking in terms of absolute incidence. But in relative incidence, Maine, New Hampshire, and Vermont, and these three states happen to be our neighboring states just south of Quebec. But when we look at our own figures, and just to mention that, as you see, the rate is well above 125 for New Hampshire per 100,000 population, 160 for Maine, and even 170 for Vermont in 2019. Same year, 2019, this is Canada Public Health data. We see that all over Canada, with the exception of Nova Scotia, which is around 85, the incidence, the rate of incidence is below 10. Sometimes in British Columbia, for example, below 1. So is there an explanation with that? Is there any convincing argument that that shows this drastic difference between Nova Scotia, Vermont, New Hampshire, and Maine, and southern part of Canada, especially Quebec, which is in the vicinity of these three most important Lyme centers. Of course, human habitat is full of boundaries, but animal habitat has, in fact, no boundaries. For thousands of years, the ticks and their carriers, their hosts have gone around without any frontier or borders. So the real habitat of the ticks is a territory which, of course, encompasses the North England, the New England, northern states, including New Hampshire, Vermont, and Maine, but also part of the Quebec, which is very forested in a big part of the Eastern Township. So if we go into the detail of the counties, you see that, for example, in Maine, we can go into the detail, and also in New Hampshire. I won't go into all the detail of that, but if we paste these counties that are bordering on Quebec, as you see, the incidence rates are somewhere between 20 and 250 per 100,000. This is for New Hampshire and Vermont, as you see. I'm sorry, Maine and New Hampshire. For Vermont is the case. And if we go into details of Quebec, also in the region of Estrie, which is the Eastern Townships just north of the border of these three states, and where the access to care is much higher than some other places contiguous to the US territory, but especially where people are more aware of Lyme disease, you see that the incidence rate for 2021 is 73, which is much closer and much realistically comparable in a geographical and organic manner with a habitat which is common. So it's 73, but elsewhere it drops to 7 and then almost close to nothing. So when we look at the reality, as you see from Vermont to Maine and also Nova Scotia and also upstate New York, the figures of the incidence rates are all somewhere between 80 and 170. For Eastern Townships bordering Vermont and New Hampshire, it's 74. But all over the place, the rest of Quebec, the figures dramatically drop, as is the case for New Brunswick. So I think, in terms of the science of it, there is no convincing reason that can explain why, without natural borders, there is such a big drop in the incidence of Lyme disease, other than underreporting, underdiagnosis, which is the impression and the observation of many patients since many years. I won't go into detail of that, but as you see, active surveillance by Public Health of Canada shows that we, in all 3 provinces and 45 sites, ticks, black-leg ticks, are heavily infected with the spirochete of Lyme disease, with Borrelia burgdorferi. And as you see, it's the case also in Ontario. There is a high incidence, high infection rate of positive ticks for Lyme and for other tick-borne diseases. So the conclusion is that Quebec is bordered by 3 US states that have the highest incident rates of Lyme disease since the last 10 years, if you go back and check all the data, equaled only in the world actually by 4 other territories: Estonia, Lithuania, Slovenia, and Switzerland. All of these have rates higher than 100 cases per 100,000. The other fact is that tick habitat is slowly moving through the north by climatic change. On the other hand, Ixodes scapularis, the transmitting tick, has high level of carriage of Lyme disease and other diseases. So if we take into account these 3 factors, Quebec, if not already there, is soon to become one of the major, if not the epicenter of the emerging Lyme disease. And what can be said about Quebec can also be said about Nova Scotia, New Brunswick, and Southern Ontario. But when we look at the declared cases, and the incident rates registered. Unfortunately, there is a big gap between this reality and what is. So, what is the impact of long-term antibiotics? In our observation at La Clinique des Maladies Victorielles. Clinique des Maladies Victorielles just means tick-borne diseases clinic that opened in my hospital. A few words about why are we talking about chronic Lyme or persistent symptoms due to Lyme disease or otherwise defined long-term symptoms after a Lyme disease, whether it's treated or not. By citing Clyderan, I wanted to underline the fact that everybody now recognizes that there might be elements in the strain of the bacteria itself, its composition, its variability, that have an impact on the effectiveness of current diagnosis and clinical presentation of the disease, and the lack of evidence on strategies of prevention and intervention to reduce the risk of these long-term sequelae, however we define them. IDSA itself, in its 2020 clinical guideline for Lyme disease, recognizes that there is important gaps existing about the long-term consequences of Lyme disease. Even if it's disputed, what is the reason of this persistent symptom, but they recognize that 10 to 15% of patients will experience long-term consequences. And about the incidence of this long-term symptoms, the latest and most reliable figure comes out of a study by John Alcott from Johns Hopkins and his team that assessed the risk of post-treatment Lyme disease in patients which were ideally treated early for their Lyme disease, not taking into account patients that were not treated. And even in those patients that were ideally treated, there was 13.7% of participants with a history of prior Lyme disease that were treated that met afterward the criteria of post-treatment Lyme disease. So we have a relatively big problem of persistent symptoms. They are differently defined, as I mentioned. France's equivalent of CDC, which is called Haute Autorité de la Santé, in 2008 defined a syndrome called persistent polymorphic syndrome post a tick bite. ILADS, the International Lyme and Associated Disease Association, has in 2019 produced an important paper defining its approach to Lyme disease and talks about chronic Lyme. My colleagues remember that IDSA went into much length in its 2006 guideline about post-treatment, PTLDS, post-treatment Lyme disease syndrome on many pages. But in the 2020 version of its guideline, IDSA is very, how do you say it? Very brief and does not mention anymore post-treatment Lyme disease syndrome, recognizing that these prolonged syndromes are not necessarily as defined before, are not for sure related to something else than an active infection. By redefining its terminology, they take into account the possibility that there might be also an active infection, even if we don't know for sure for the moment. So they talk now about the prolonged symptoms following treatment of Lyme disease. And the INES, l'Institut National d'Excellence en Santé in Quebec, has defined the persistent symptoms attributed to Lyme disease. So there are many ways of talking about this chronic problem, whether it's a sequel, whether it's a consequence of active infection, but we all realize that there is a problem concerning about 14% of the patients. Another impact that we have to take into account is that even in the United States, in northeastern United States, with good tools for reporting the disease, there is a high discrepancy between reported cases and total estimates of people infected each year. And the method to find about those not declared to public health officials is through their insurances in the United States, and there is a 1 to 10 gap about these cases. So if we come to Quebec and Ontario, the southeastern Quebec, and we don't take Vermont, Maine, or New Hampshire as identical to southeastern Ontario and Quebec, because we have high density populated areas. But we just take the incidence rate of New York, which is 20 by 100,000. We calculate for Quebec and Ontario over our population. That makes 44,000 people each year that could have Lyme disease as an incidence rate. As total incidence. And if we calculate based on the John Occott papers rate of persistent symptoms, that means yearly in Ontario and Quebec, we're facing with epidemic touching 6,000 Lyme patients, which even with appropriate Lyme treatment will end up with persistent symptoms. So it's a real issue that we have to tackle. That's why the Association Québécoise de la Maladie de Lyme set up a petition in 2017. I was there in the National Assembly at the time. As I mentioned, the Health Commission organized hearings. We then made a report to the health authorities, which came up in 2022 with the announcement of a budget of 21 million for 2 years to set up clinics to take care of chronic Lyme patients, but also long-haul COVID or COVID long, because it was, in fact, long COVID was a type of eye-opener for the authorities to realize that even after the resolution of an infection, as we know in many other cases now, we can have lingering symptoms of those diseases that we'll have to take care. So when these things happened, soon after that March hearing, the reality is that I had to announce my retirement, which took place in the month of May. And I realized that in the week that I announced my retirement from active politics and returning to active medicine, the telephone began ringing in our external clinic, and a lot of patients by their own took appointment with me. So it brought me to face some clinical situations with many patients that gave me an opportunity to realize that there were clinical settings with many coherent, uniform clinical pictures among people that had erythema migrans, which had the typical erythema rash of Lyme, despite the fact that part of them had serological proof of their disease and part of them had serology that didn't show the presence of Lyme disease based on standard definition. But when you looked at their evolution, when you looked at their symptoms, when you looked at what happened in their life and in their quality of life, everything else was quite similar. So that opened one window of understanding for me. But there were also some few striking cases that I won't go into detail that made me realize that we have a real problem, because before that, for an infectious disease specialist as me, Lyme disease was simple, very easy to diagnose, difficult to contract, very easy to diagnose, and very easy to treat. And we didn't have such a thing as a chronic Lyme. So after realizing that I have to change paradigm in approaching these patients, I went to see the chief executive officer of my hospital, who had a patient in his relatives who had the same problem. So he was very open-minded about that, allowed us to open up a clinic and provided sufficient fund for the clinic to begin to operate. And as I said, I had also the collaboration of my colleagues to leave me some available time to take care of this clinic. So we will talk about this registry of patients. So this clinic opened in April 2019. And we were able pretty much to see almost half of the 500 patients we have seen in the first year before the pandemic. The problem, of course, was that since the beginning of the pandemic, since the last 3 years, we have lost the opportunity to have a full-time nurse. Even now, 1 year after, out of the most traumatic years of the pandemic, because of the shortage of nursing, I only have 1 day in a week and sometimes even less. The referrals to the clinic are mainly self-referred, but in 40% of cases we had doctors referring patients to our clinic. Among these doctors, I have to mention few of them are my own colleagues, infectious disease doctors of my own hospitals, but also infectious disease hospitals elsewhere in Quebec, and a few of them that I won't name, even in high-profile university settings, that felt unease themselves to provide long-term antibiotics for these patients, but were so much convinced that there was something going on that must be related to Lyme that they referred their patients to this pilot project, considering the fact that we had this approach of providing long-term antibiotics. So I mentioned that not to judge anybody, but just to say that there is a shift in paradigm, not only for people like me, but a lot of my colleagues also began to realize, especially I think COVID long had an impact on that, that we have to consider Lyme disease with more complexity than we used to do. And there might be benefit in long-term antibiotics, among other things, providing that we carefully exclude other diagnoses and also take the time to pinpoint what is involved in these persistent symptoms patients. So what the patients do, they describe by email their history, they provide their medical files. We do before the clinic a baseline workup beforehand and relevant serologies. Then at the clinic, there is a first evaluation by the nurse, the standard questionnaire of Horowitz to rate their symptoms, a detailed assessment by the nurse of the essentials. And there's also afterward a medical consultation with me that on average takes 1 hour and a half in the first instance for all together with history taking and writing. And based on that first evaluation, we prescribe additional tests. We sometimes refer to other consultants. And our task is greatly helped by the fact that the great majority of our patients have already seen many other consultants and often other infectious disease professionals to rule out other diseases. So the diagnostic orientation intervention is not that difficult. Despite that, in our clinic, we have regularly to exclude other possibilities because we have seen people, of course, with myalgic encephalomyelitis, but also with specific autoimmune diseases, as mentioned here, rheumatoid arthritis, children. I have all those that are mentioned here, I have had them in my clinic. Ehlers-Danlos syndrome, multiple sclerosis, Parkinson, a case of myasthenia. We have also sometimes just adrenal insufficiency with profound fatigue, sometimes psychological, and even in few cases psychiatric problems that we had to refer, but also other infections like post-dengue syndrome. We have 2 cases, Powassan syndrome in a forest worker in Laurentian, Quebec, who had acquired his Powassan in Quebec. Whipple's disease, 2 cases, Q fever, Bartonellosis. Anyhow, you see all those cases. So this is to mention that these patients that come in, of course, don't have a sticker on their front indicating that they have Lyme disease for sure. We have to take care to exclude other diagnoses. And then if we decide to go on with prolonged antibiotherapy, of course, they have to sign a consent form. We take time. That's why it takes so much time to go into generous explanation about the rationale behind that. We take care in explaining that bacterial persistence for which we give these antibiotics is only 1/3 of the possibilities that we don't know in advance. Since we don't know, we take that possibility as one treatable possibility, but there are other possibilities. And we provide them written information by email about autoimmune diseases that cause dysautonomia or other treatable neurological diseases. We indicate also the other possibility is that there is nothing really active, and all there is a sequel of some trigger, infectious or other, or treatable, or we hope in soon treatable or yet untreatable myalgic encephalomyelitis, because when you're stuck with profound neurocognitive impairment, fatigue, and neurosensitive problems without explanation, without even Lyme to explain for it, well, you end up in the category of myalgic encephalomyelitis, ME. And of course, we reiterate the importance of the possibility of side effects, considering that it's considering the non-validated nature of our treatment. We have to take care of going into much detail about that. Patients received antibiotic prescriptions. The first antibiotic prescriptions goes for a minimum of 3 months. There is monthly follow-up for baseline and serial liver functions. And by email, people receive written explanations, contact informations in case of side effects. And in all cases, these things are managed by the clerk or the nurse or both of them. So the registered nurse is due to make to check the liver enzyme test to ensure that we take advance into possible problems, and people receive replies by the nurse about their side effects, the intolerances, the adjustments to do. We have also a weighted table of symptoms that we call tableau pondéré des symptômes, where we identify the 6 most disabling symptoms of patients, and we ask them to weigh it from, it's written here 1 to 10, in fact it's 0 to 10 every 2 weeks, in the beginning and at the middle of each month. And we try to ensure a medical follow-up assessment every 2 to 4 months. So the patient registry, I won't go into detail now. We have seen 538 patients from 2018. So it's a retrospective cohort. For the purpose of our cohort and its institutional validation, it's a prospective observational cohort study. Among these 538 patients, we have complete entry for the data of 468 patients. And among those, we have identified persistent Lyme after excluding 78 patients who had other diagnoses. We have identified 390 patients with persistent Lyme. So these, the total of these 468 patients are in the database called Access, which is analyzed with the SPSS software. And as I mentioned, my colleague and companion in life, Dr. Nima Mashouf, who's an epidemiologist, has carried the statistical analysis. So the two questions of interest that I will try to respond in the remaining time I have, in the 10 next minutes, is are these prolonged antibiotic therapy useful to treat persistent symptoms after serologically proven Lyme disease or clinically probable Lyme disease? And I will explain why this distinction, because we don't require in our approach that people have positive serology based on standard criteria. And if these antibiotics are useful, does the benefit justify a therapeutic trial in patients with the same clinical and epidemiological picture, but without the supporting serological evidence or the erythema migrans evidence that would be considered in the first instance? So if these antibiotics are useful in those patients for whom we have an idea, a clear idea that they have had Lyme disease, if the harm done by these antibiotics in the long term are not important, the side effects are tolerable, could it be beneficial to justify a therapeutic trial, even if patients without the clinical and epidemiological picture, without, I mean, the serological proof of the disease? And I remind you that even in 2022, when you go at the CDC's site, they take caution to specify that the criteria, the serological criteria, are useful for case definitions for public health screening of large population. But surveillance case definitions are not really intended to be used by healthcare providers for making appropriate clinical diagnosis. And a lot of my colleagues know that very well, because clinical diagnosis enters into consideration the pre-test probability. And when the pre-test probability is high, the importance of false positives falls a lot in the predictive value of tests. The positive predictive value of tests goes high, so one can reliably, even in the absence sometimes of serological proof, based on clinical grounds, diagnose Lyme disease. And in fact, when you look at the gradual shift of opinion, even among the Infectious Disease Society of America, the IDSA, leaders on Lyme disease, as I mentioned before, there is a recognition that there are patients with persistent symptoms following standard treatment, and there is not much emphasis put on trying to convince that there is no infection. There is just a realization that we should do something about it. So this approaches all the other groups, or I would say instances where expert groups have opinion that there is something called chronic Lyme, put in many different words. So I'm talking about the tick-borne disease working group that made under the auspices of John Olcott from Johns Hopkins, who made a report to Congress late 2018. It's the case, of course, of the ILADS in their paper in 2018, but also the Quebec Institute of Excellency in Health in 2021. And the most interesting of them, or the one instance that goes the furthest, is the Haute Autorité Sanitaire en France, so the High Authority of Health in France, which in 2018 is talking about also syndrome persistant polymorphe après possible piqûre de tique. So even if there is not recorded evidence of tick biting, but if there is enough epidemiological evidence to support the fact that there is a high risk of exposure to tick, If the clinical symptoms are polymorphous and persistent and are not explainable by other causes, it might be Lyme. It's a syndrome that could be treated as a Lyme disease syndrome. So I'm just going over these elements: polymorphic, persistent, intermittent. They're disabling, and they're not otherwise explained by other diagnoses, despite investigation. In our clinic, they might have had erythemal migrants, but they can be without erythemal migrants. They could be with observed tick or just likelihood of exposure to ticks, but there must be a high likelihood of exposure to ticks. But it can be with or without prior antibiotic treatment for Lyme disease. So this is the definition of our patient group, the Lyme disease, of our group of Lyme disease patients with persistent symptoms. I go very fast in the cohort description. As you see, 65% of our cohort are female. The age average is 46, and the interquintile rate is 37 to 56. And there is, interestingly, life experience in the family, which just denotes that these people come from areas of Quebec or elsewhere that they are highly exposed to Lyme disease. So they have had somebody in their family that had the experience, so they are much more aware and seek treatment and evaluation more frequently than others. So they are 20% of the cohort. The disease characteristics: fatigue in almost 90% of them, arthralgia, myalgia, headache, and especially neurocognitive symptoms. All of you know that these patients come into office and one of their main symptoms is, and they say, "Doctor, I have a brain fog, I cannot explain it, and I have memory and concentration problem." So, of course, as I mentioned, we have identified in many of our patients concomitant diseases also, because they come with sometimes the diagnosis of fibromyalgia, or we are able to refer them to the CHUM with our specialist, Dr. Camille Laflamme at the Centre Hospitalier Universitaire de Montréal, and they have some type of Ehlers-Danlos syndrome that can be a predisposing condition, genetic condition, to have problems with chronic, viral or Lyme type infections. Multiple sclerosis in 7% of our patients, and also conditions of mast cell activations or pre-existing dysautonomia, although dysautonomia is a part of the symptoms. I want to mention the fact that the burden of the disease is very important in this group of patients. The third of the patients were so much invalid that they were on sick leave, sometimes for years. In 9% of them, we had suicidal ideas and, in many instances, attempts of suicide. And as you know, in Quebec, in the last 6 to 7 years, we have had more than 8 suicides linked to Lyme, and a notorious one just happened at the end of last summer. And even in 5 cases, these patients, before coming and see me, and one of those striking cases that I saw that improved dramatically under antibiotic therapy, before coming and seeing me, her own parents were helping her, seeking medical aid in dying, because she was draining all the family, and out of despair, she had convinced all her entourage that it might be better that she died instead of sinking all her surrounding with her. And another fact is that they had seen a mean of 3.5 other specialists, rheumatologists, neurologists, internal medicine. And as you see, the IQR is 1 to 4, but we had also patients with 14 different specialities, not only doctors, but that I had seen. This is the burden of their symptoms in terms of Horowitz score. When you have more than 46 in the Horowitz score scale, you have a probable Lyme disease, chronic Lyme symptom, if you wish. So 83% of my patients were in that category, sometimes with very high scores. So here again, it's the number of specialties consulted. Another factor that made me take some time to see if we can do something in Quebec for these patients is that a lot of them were seeking help in the United States, and because the United States is private medicine, some of them were just ruining themselves financially for that matter. Sorry, I'm coming there. We are arriving at the result of that. So this is the classification of our patients. We have, as you see at the bottom, 21 patients out of the 468 that had positive serology based on standard criteria or positive ELISA, but missing confirmation Western blot or negative Western blot and negative Western blot confirmation. In our clinic, in our approach model of care, we considered them because they had the clinical picture and the epidemiological background, which was very plausible. We considered them eligible to treatment. There were also some patients with negative ELISAs, but positive erythema migrans, and in a majority of cases with picture. So we included them in our cohort. And there were also instances of ELISA negative, in the absence of erythema migrans, but with a clear history of tick biting and all the clinical and epidemiological relevant element in their history. But also 110 patients without all these, even without having the tick history observed, but with a high plausibility of tick exposure and a strong epidemiology going with it, with a consistent clinical syndrome. This is the SPPT, the France authority definition, if you wish, of chronic Lyme in their approach. I won't go into the detail of these two others. Did we treat everyone? No, because as you have seen in this here, there were other tick-borne diseases that were identified or other infectious diseases and no evidence of tick-borne disease. So those ones were excluded. So not all patients coming to my clinic were treated. The choice of treatment, the baseline was doxycycline, azithromycin, and rifampicin, and the minimum length of treatment was 3 months. 83% of patients had the 3 months. 75% of the total patients had more than 6 months, up to 6 months, and so on. And as you see, half the patients had antibiotic duration of more than a year. And at the left side, you see the type of drugs that we used as baseline, but sometimes as a alternative when there were intolerances to existing drugs given. So this is the result of the impact of long-term antibiotic treatment for our patients. As you see, and I'm going to try to finish with that, when you look at serologically standard, based on standard criteria, serologically proven cases, which are just 21 among my 390 patients. Why? Because a lot of them had, because they were proven, had treatment initially, so you don't expect many of them having lingering symptoms. So we don't have many of those. They were taken well care of, they were believed by their doctors, so they didn't end up without appropriate care, lingering from here to here in doctor offices without answer. There were also ELISA positive, but missing or absent Western blot confirmation. We have 35% patients like this, and the rest of it are all those categories that I mentioned. But when you look at the response to treatment, 2/3 of the patients, on average, undistinguishable between categories, respond well. What is the R3+ response rate? That means a functional response rate based on Horowitz or that table of symptoms and a quality evaluation by myself at the clinic on follow-up with all the bias that one could imagine within the framework of my clinic. 2/3 of patients had considerable, more than 70% improvement of the burden of their disease, and the equivalent is that of their functional capacity had improved 70%. There is no statistical differences between these three different categories. And important to note, 30% of those who were on sick leave that I mentioned before having antibiotic therapy went back to work sometimes in the middle, but sometimes at the end of their treatment. So there is a reduction of the symptoms after antibiotic therapy. And I will end, okay, I have to talk about the harm of long-term antibiotic treatment. I won't go into the details of this. We had 44% of patients that reported some form of adverse events. There were two important adverse events that needed, in one case, even hospitalization. That was Clostridium difficile colitis. And in these two patients, after appropriate treatment, they returned back to normal. None of these adverse events represented a serious enough event to cause what patients considered harm or any reason to abandon wholeheartedly all form of antibiotic therapy. Veronica, I end my discussion here because we'll lack time.
Perfect. Thank you so much, Dr. Khadir, for your presentation. I just wanted to touch base with you on your availability. We do have a number of questions, so I wanted to know what's your hard cutoff, because I do know you have other commitments for answering questions.
I will be with you as long as it requires until 1:30.
Okay, perfect. We're going to start with the first individual that put their questions in the chat box. Hi, can you explain the correlation with COVID-19 that might reactivate Lyme tick-borne diseases with or without long COVID, and how to know the difference with the poor test we have in Canada? That's the first question.
My answer to that is that poor test, if we mean by poor test, Lyme disease tests that are not able, standard Lyme disease tests that are not able appropriately to pick up people at some point in their long-term symptoms. It's the same situation everywhere in the world. It's not only Canada. Now, the interrelationship, the correlation with COVID-19, in my understanding, as has been noticed by many investigators and people who have a hand in this, at some point in time, when Lyme causes long-term symptoms, there is a dysregulation, which we didn't have the opportunity to abort because of time, which has nothing to do with the presence of the infection at low level itself in deep-seated tissues, but with the dysregulation, whether it's autoimmune, whether it is some other direct effect of on one of the physiological functions of our body that explains some symptoms. One of the main components of that is dysautonomia, or low-level inflammation of the vagus nerve. And as we know, the vagus nerve has itself a role in controlling immunity, in controlling inflammation. So whether it's Lyme or COVID that comes first, at some point, if somebody has had one of these two infections first, the second one can trigger again an activation of all those dysregulation problem witnessed with the first infection. So of course, one disease can trigger the other, but I have had two instances of the contrary. I had patients which were followed in my clinic that after acquiring COVID and going through their COVID infection, mild cases in both instances, they miraculously were better in all other regards and were their chronic Lyme symptoms, indicating that somewhere in the process of the immune resetting and buildup to fight the COVID infection, that immune reallocation stopped their previous dysregulation. So these are the type of questions that appropriate research scientists, because I'm not a research scientist, I'm just presenting my observations of 5 years of practice, but appropriate research questions must be addressed, and I think some teams in US are already tackling them.
Thank you. I'll move on to the next question. Dr. Neil Nathan, an integrative medicine physician in the USA, reports that 80% of Lyme cases not responding to antibiotics are colonized with molds and mycotoxins. They heal when you treat the molds and mycotoxins. What do you think?
I have had this type of affirmation and assertions in these last 5 years. Frankly speaking, I cannot comment in an intelligent manner on this issue because I haven't had the opportunity to look into it appropriately. But chronic mold infection is a disputed matter, as much disputed as chronic Lyme disease. So if we have to enter in another battle on top of the chronic Lyme, we'll have problem building up at least a consensus of the necessity of tackle chronic Lyme disease.
Thank you for your response. Okay, the next question is another one related to Lyme and COVID. How do you differentiate between Lyme and long COVID if it is a co-infection or a reactivation following the collapse of the immune system? Unfortunately, these two diseases are diagnosed with exclusions of the others.
Well, that's a good question and has no answer. If there is remote serological evidence of past Lyme disease, considering the fact that during the COVID pandemic, people had very low exposure to other diseases. We were confined at home. We had little activity outside. So anything that happened as an acute infection beginning during the COVID pandemic, most probably is due to COVID, and then one has to sort that out and differentiate it with past Lyme infection if there are other epidemiological, clinical, or serological evidence of past Lyme infection. But for any one person who comes today and doesn't know exactly when these symptoms began, and there is a history of exposure to ticks in outdoor activities, it will be very difficult to distinguish.
Thank you. Our next question, do you recommend other supportive therapies such as working with a naturopath to ensure that they have vitamin and mineral supplementation or etc.?
In our clinic, we provide some supplementation. There are two that we provide ourselves. The first is low-dose naltrexone, which has been shown in many chronic problems like multiple sclerosis or inflammatory bowel diseases like Crohn's disease to act as immunomodulators, diminishing the bouts of acute inflammation. So low-dose naltrexone and aged garlic extract, which also has anti-inflammatory properties. Actually, I didn't mention that the first, since a year and a half now, the first 6 weeks of the beginning of the treatment in my clinic is just these two products, low-dose naltrexone and aged garlic extract, which are both in low doses. If the patient finds appropriate alleviation of his or her symptoms just with these two, the patient is advised to contact us to reevaluate and possibly just suspend antibiotic treatment.
Thank you. The next question, you may have touched on it in your last question. Do you prescribe the same cocktail of meds to all patients, or do you customize it? What is your cocktail of choice these days, since it seems to evolve? Merci.
The first line of treatment for all patients who are naive to long-term treatment is doxycycline, azithromycin, and rifampicin. But there are instances where patients come to my office after having had this for some time with other doctors, with US doctors, or even in Quebec in the last 1 year and a half, there was a colleague of mine, Dr. Sophie Michaud, who was also carrying this type of treatments. So in those cases, it's tailored based on where they're up to. So sometimes I would give ceftriaxone intravenously. Sometimes they would receive disulfiram since the publication of Dr. Ligner's report of 3 patients, we included that in our pilot project for those patients who have had more than 6 months of doxy, azithromycin, and rifampicin and shown some improvement. And for those patients, especially who had neurocognitive impairment, because that seemed to be the best output of disulfiram, we would begin with disulfiram.
Thank you. Is the definition of MS clear, or is it Lyme frequently misdiagnosed as MS? The patients remain contested, and diagnosis may depend on what lens the specialist is using. And it was noted medicine is a highly siloed profession.
So we know now that MS is linked, most probably since the publication in Nature last year, if I don't make mistake, in Nature or Lancet, I can't remember, of that cohort of 10 million US soldiers who were screened, that the most important factor in occurrence of multiple sclerosis is EBV infection, Epstein-Barr virus or mononucleosis infection in the previous 5 to 10 years of their multiple sclerosis. And what is the conundrum of multiple, what is the hallmark of multiple sclerosis is some tache, comment on dit tache en anglais, lesions of the white matter of the brain on MRI. When they are classical, there is no doubt. But some of my patients that come from highly endemic southern Quebec, who have had exposure to tick, who have had erythema migrans, and who had these lesions and were diagnosed as atypical multiple sclerosis, responded well to antibiotic treatment. And I see a lot of patients which were not categorized as multiple sclerosis, as MS, because their lesions of white matter was not typical and came to treatment. We put them in treatment and part of them respond appropriately, sometimes amazingly. So we should admit that Epstein-Barr or whatever is the trigger of MS is not the only infectious pathogen that could eventually trigger some lesions of the white matter of the brain. And sometimes it's just difficult to distinguish.
Thank you. We've got 2 more questions in the chat box, and then if time allows, we can open it up to the audience for 1 or 2 questions. Would you like to see more fine tissue research undertaken to search for a microbial cause of many of these invisible diseases, such as ME/CF question mark. In the case of ME/CFS, they don't know what they're looking for and looking in the wrong places. Someone has noted also references to papers that Oxy and other papers show cultural PCR serology confirm Lyme and MS, including brain biopsies with imaging, and they reference the work of Alan McDonald related to other viral bacterial parasitic association.
I don't think I have the appropriate competence to answer all these questions embedded one into each other. I realize at least, that these, I would say, universe of symptoms or ensemble of symptoms that Lyme patients have, other types of post-infectious lingering symptoms or syndromes like COVID lungs have, or those of other diseases like post-dengue, post-Powassan, have a lot in common with myalgic encephalomyelitis. Is myalgic encephalomyelitis the end of a pathophysiological pathways that has gone wrong and chronic forever? Might be. It's plausible. A lot of people think that, but in the process, of course, there are a lot of these syndromes that will look like one in another, and we need appropriate tools. I know, for instance, that the myalgic encephalitis research network is based in Quebec. Professor Alain Moreau, he's now doing a lot of high throughput analysis on biological markers, microRNAs, to see if there is an association with 3 or 4 different categories of myalgic encephalomyelitis. But we are all in the beginning of these investigations.
Thank you. And our last question in the chat box is, don't many ILADS physicians use a combination of antibiotics to take care of the different forms of the bacteria it can take? Doxycycline is bacteriostatic and won't even kill this bug in a test tube using the mic dose.
Yeah, that's an interesting question. I haven't had the opportunity to indicate recent findings just published in the June number of emerging infectious disease by the same team that is quoted by the IDSA in proof of the fact that there is probably no relation between Lyme disease and the chronic lingering symptoms that these patients are witnessing. Just recently, the same team in Slovenia made a correlation with TNF-alpha in blood, high levels of TNF-alpha, and chronic symptoms after Lyme neuroborreliosis. Why I'm saying that? It's because we know today, we know from a long time that doxycycline is not only an antibiotic, it's also an anti-inflammatory. And remind you what I said, persistent infection is only part of the problem. Probably just a subgroup of patients have persistent infection. Probably in many cases, we're dealing with autoimmune diseases with low-level inflammation that is disturbing many physiological processes, including dysautonomia. So the role of doxycycline here is to act double-wise. How do you say it? In 2 ways. Act as an antibiotic where it's needed. And of course, it's not bactericidal, but in long term, by combining 3 antibiotics together, we overcome that shortcoming of its of not being bactericidal. But on the other hand, we want to have a compound that also has anti-inflammatory properties. That's why a lot of doctors still use doxycycline as one of the main, how do you say it, holes of the approach.
Thank you. We've come to the end of all the questions in the chat box. Just recognizing a time, I will open it up if somebody from the audience wants to raise their hand icon and ask a question. We can take 1 more question from the audience. Otherwise, we'll wrap it up for today, and I'll give you an update on our presentation tomorrow. Do we have a final question from the audience? Go ahead, Dr. Kaladi.
Just a quick question. Thanks a lot for that talk. It was fascinating. I was wondering about, just playing devil's advocate, what you think about the idea of placebo effect and, how that one might disentangle that. I know you have some, you have these sort of long term, so maybe there's a temporal aspect to it or something like that, but I just want to get your thoughts on that.
I'm sure there is considerable bias introduced in all my figures by this placebo effect, by my own blinded manner of evaluating the patients, of course. But as I mentioned, there were, we have to see sufficient patient, because that was my first intuition when in the beginning these patients came to see me when I was a politician, because in my experience, when they talked about being relieved by antibiotics, I said, yes, we know the placebo effects of antibiotics. But there were some eye-opening and very striking histories that brought me to realize and see more and more of patients where placebo effect has nothing to do. One of them is that same patient, that woman that I told in my presentation that was seeking medical aid for end of life, okay? Medical aid for dying that exists in Quebec. She was going to surgery, but just before going to surgery, she had she was going to surgery for an abscess in her pelvis, because she had also Ehlers-Danlos syndrome that I told you can be a genetic predisposition to complicate from infections, especially intracellular infections of the autoimmunity that comes in. So that patient had an abscess, an important abscess, that had to go to surgery, but before the surgery, the doctor gave her, and for some reason, not clavulin, for example, or beta-lactams, because of, I think, some intolerance, but doxycycline. And that patient that was sick for 4 years and bedridden, unable to take a shower for 3 weeks, when she came to me, she said that when I was given 10 days of doxycycline, I reversed almost to my pre-disease state, and the surgery was canceled. So, and that improvement of her abscess and improvement of her physical situation was testified by the doctors that saw her. So at some point, we have to take some and leave some. There are important component of placebo effect, but let it be, because, I didn't mention that a great majority of these patients, when they are not finding appropriate approach, they, little by little, they are under 4 types of different drugs: analgesics, neuroleptics for their pain, anti-anxiety drugs, and antidepressants. So, and they're under these drugs for sometimes months, if not years. And we don't see the same, how do you say it, placebo effect. And would we want patients to be lifelong on 4 different neuroleptic drugs or which have neuro impact drugs, or try for 6 months, for 12 months, for 18 months antibiotics? That's the question.
Yeah, is there a temporal component? I mean, I wonder if you could, make the argument that the placebo effect would be fairly immediate, whereas the antibiotic effect would have more of a temporal change. Because I notice you have different lengths of application for different patients.
In fact, maybe what is going against the placebo effect is that almost all my patients in the first 2 to 3 weeks are experiencing a deep worsening of their symptoms, what we used to call, I don't know if it's truly a Herxheimer reaction, but in the community, they call it Herx reaction. And we warn them against that. And some of them are surprised and have tendency to abandon the antibiotics because they see a dramatic deterioration. So this does go against, as you mentioned, the placebo effect. Yeah.
Great, thank you.
Thank you. Thank you, Dr. Khaladi and Dr. Khadir. Okay, we're going to wrap it up with the last two questions. We'll go over to Dr. Bordeaux, who's got his hand up, and then I have one last question in the chat that we'll ask, and we'll wrap things up.
Yeah, thank you so much. Really, really fascinating talk. I was just wondering, I mean, so the antibiotics are working for these patients. You just mentioned the Herxheimer reaction. So that seems to suggest then maybe that these patients have persistent spirochete infections that are being resolved. But then you also mentioned that, you know, it could be a dysregulation of the immune system, and that some of these drugs like doxycycline, that they have anti-inflammatory properties that could perhaps help in resetting the immune system. So I'm just curious, and I realize you might not have an answer to this, but where do you feel like, does your data, does it suggest more of a long-term spirochete infection for you for these individuals, or do you think there's also still a role for immune dysregulation?
Dr. Bordeaux, you know, I need help from people like you or others to dig into that those data that I have to exactly ask those specific questions and find the appropriate answers. I haven't had neither the time, neither the idea, the intelligence of asking those appropriate questions. But of course, it's very easy to understand that if these drugs have anti-inflammatory properties, they might sometimes have even paradoxical effect in the beginning of their impact. And so there is nothing about antibiotic activity that explains neither the improvement nor what we think is a Herx reaction. I don't know. So these are the type of answers that we have to answer. But I attract your attention again in this last mention I made of the paper in the Emerging Infectious Disease of June 2023 about the high level of TNF alpha and I think interleukin 6 in the blood of patients who had neuroborreliosis. And then you see that doxycycline and even azithromycin at a lower level have both activities against these two markers. So, you know, this is a whole I would say field of interrogation in front of us.
Right. Thank you. Thank you very much.
Thank you for your question. Okay, final question. Thank you for an interesting presentation. Is there a time when serological tests are negative and you are considering whether to treat with antibiotics? How do you decide whether the epidemiological context fits? Do you consult specific maps or other criteria?
Well, we don't consult maps per se, but we question heavily about their all their activities before becoming sick in terms of outdoor activities, acquaintance of pets, their travel history, and take a considerable time and sometimes ask them to go and dig into the pictures they have taken, if they have had somebody noticed or taken a picture of their skin when they had some redness that they didn't understand. So we try to pile up evidence to see if there is evidence or not of plausible tick exposure. But sometimes, and as you mentioned, we don't find any of these, so we just exclude them from our. They don't fit. They're not eligible to our approach.
Thank you so much. Well, I want to take this opportunity to personally thank Dr. Khadir for spending this extra time with us, for your presentation, for sticking around and addressing all the questions from the audience. Thank you so much. I do want to remind everybody that we are continuing our presentations the rest of this week. Jenna Noss, who's a medical student from Dalhousie University, will be presenting tomorrow at 1 o'clock Eastern Time on the topic Clinical Presentation and Outcomes of Children Treated with Lyme Arthritis, Experience from a Large Pediatric Cohort in Nova Scotia, Canada. So we hope you can tune in tomorrow for that discussion. Also, a reminder to take part in our challenge, Wear Green, take a photo and share it with us to help spread awareness of Lyme disease and tick-borne diseases. You can also send photos of your creative artwork, whether it's a drawing, a sketch, pottery, poetry. Take a photo, send it in. All photos received will be automatically entered into a draw for a chance of one of 4 $25 Starbucks e-gift cards. The live draw will be occurring on our last day of our presentations on May 31st. And send your photos into clydern@gmail.com along with your name and email. And finally, just a reminder that TICNET Canada will be having its inaugural scientific symposium in person in Toronto, Ontario, on October 24th and 25th. The planning committee is just finalizing its details, and we're hoping to open up registration and abstract submission June 1st. We're hoping to have more detail to you later this month, so stay tuned. Again, if you have missed any of the presentations that have occurred throughout this month and you are not a member of our portal yet, just send an email to clydern@gmail.com. We can give you access to our portal where you'll find all the presentations that have been recorded throughout this month, as well as last year and the year prior, that you can watch at your own leisure. Again, I do want to thank everybody for tuning in today. And again, Dr. Khadir, for your presentation. I hope you guys have a great rest of your day and great rest of your week, and hope to see you the rest of the month. Take care.
Merci beaucoup.